First of all, thank you very much, the organizing committee and all of you for inviting me. It is my great pleasure to be here. What I'm going to talk about is the transcatheter mitral therapies. I tell people that mitral valve is the beautiful valve. It's like a lady valve compared to the aortic valve. And it is a high pressure valve. It withstands more pressure than the aortic valve. And it is a complex valve. It's difficult to figure out what is happening to the valve. Sometimes it is more fun to work with this valve. So the main question is that if you look at the mitral regurgitation, these days we divide the mitral regurgitation in primary mitral regurgitation or secondary mitral regurgitation. Instead of functional, nowadays we call it secondary mitral regurgitation. And in the primary one, there is a prolapse and flail, but there is also the MAC and rheumatic heart disease. So keep that in mind, that MAC and rheumatic heart disease are primary mitral regurgitation. And secondary mitral regurgitation, we say ventricular mitral regurgitation, atrial mitral regurgitation, and there is also atrial plus ventricular mitral. Most of the mitral regurgitation is atrial plus ventricular, meaning the atria is dilated, the annulus is dilated, and the ventricle is dilated. Keep that in mind. So first, if you look at, this is a table, and I'm not going to go in the details for the interest of time, but just I made this table to say that if you wanted to put the Carpentier classification along with the primary and secondary MR, how would you put it in perspective? So this is something to keep in mind. I'll just start with the cases so that we have a practical approach. So this is a slide that we make for everything, for all the mitral aortic valve, and this we project it as one of the monitors in the cath lab so that at least people know what's happening. Now this is an 80-year-old patient, so this is a primary mitral regurgitation, 80-year-old patient with otherwise having heart failure. And it's very simple that we are going to now look at the mitral valve. So you see the mitral valve is prolapsing, but the anterior leaflet is prolapsing. So this is the anterior leaflet flail mitral valve. And if you look at this, this patient is a high risk for surgery. So whether we do high risk surgery, MVR, percutaneous mitral valve therapies, M3, Tendyne, Sapphire, Twist. These are the 4 valves that we are using currently in Cleveland Clinic, or MitraClip or Pascal. So these are the options that we discuss with the patient. But usually at 80 years of age with a flail mitral leaflet, if we can treat it with percutaneously with TEER, this is the best option. So edge-to-edge repair probably is the best option. I'll go over the transeptal puncture in the second case, which is better pictures. But I want to just highlight this particular picture to say that if you look at the RAO view of the mitral valve, this is the anterolateral commissure, this is the posteromedial commissure. Anterior and posterior leaflets are on sides of each other. And if you look at the LAO view, this is the anterolateral commissure, and this is the posteromedial commissure. Keep in mind where the left main divides is the anterolateral commissure, and when the PDA arises is the posteromedial commissure. You know where the coronaries are in any view, so that way you can tell where the mitral valve anterior and posterior leaflets are. When you do the MitraClip, the most important part of the MitraClip is that you have to align the MitraClip in a nice way, that it has to be perpendicular to the mitral valve. And many times people use a biplane view of the mitral valve, but the biplane has a limitation because it is not aligned to the mitral valve orifice. So when you are going to align the MitraClip, I personally prefer this 3D MPR. So you do the MPR, you align the mitral leaflet, and then you can see that you are perpendicular to the mitral valve and medial laterally and anterior posteriorly. And you see here that the anterior leaflet is flail, anterior leaflet is going back. Anterior leaflet flail is very difficult to repair by surgery, and it is extremely easy to clip. So anterior leaflet flail, in my opinion, is one of the good indications to consider MitraClip if you are going to use the MitraClip. And if you are on the medial side, so this is on the medial side, you will try to imagine to make the clip perpendicular to the coaptation line. So here we have put the clip perpendicular to the coaptation line, and there is still mild mitral regurgitation in this particular patient. She's 80-year-old, and the ventricular view you can see that is just lateral to the clip. Before and after, it looks good. But the most important thing is to measure the LA pressure. So the LA pressure was 70 millimeters of mercury before we did the mitral clip, and the LA pressure, the V wave, came down very nicely. So this would indicate to me that this is a reasonable thing to stop at this point, and then we can always consider to put an additional clip if the patient is having a problem. But this is an excellent result, and we can stop at that point. And there is already a little bit of a mitral gradient. So this is another reason to stop, because you are seeing the mitral gradient. So always check the mitral gradient at the end of the clip to understand that how much is the gradient. Now, this is a difficult patient. So now the second kind of patient is a mitral regurgitation with severe MAC. So this patient has a severe MAC. The gradient is not high, but what do we do with this patient? You see from the ventricular side, so much calcium on the mitral cords, mitral annulus. So this is not something, and there is a cleft right in the middle of the posterior leaflet. So this is a difficult patient to treat percutaneously. But you know, if you have enough experience and device is available, we use a Pascal device. So I used a Pascal device. So Pascal has a little bit of a spacer in between so that the size does not get so small. And as you can see, this is an outstanding result with one Pascal device right in the middle. The approval was mainly related to the non-randomized trial. So this just, I wanted to say that in the mitral clip was approved in the United States without a randomized trial for the primary mitral regurgitation. COAPT was for functional mitral regurgitation. So this was the study that did not have any randomized data. So now we are doing 2 randomized trials for primary mitral regurgitation. So one is called primary and another is called repair-MR. All comer patients. So 65 and older. So now this is a difficult ball game because we are going to have death, stroke, 2+ MR as an endpoint and mitral valve replacement. So now this is a 72-year-old lawyer who has a posterior leaflet flail, so very easy to repair surgically. Surgical outcomes are outstanding, 10 years outcome with a 95% no need for surgery. So this is a curable disease by surgery. We are now randomizing them to mitral clip versus surgery in Cleveland Clinic. So you can imagine that this is a very high bar for me to cross also. So this patient, and you look at the mitral valve, it's all messed up. So it is leaking laterally, it is leaking in the middle, and it is flailing. So if this patient, you know, I have to look in his eye and say that, okay, surgery is outstanding. He says, I really want to consider clip. So, okay, we will do a clip, but it will be randomized. So we randomize the patient in the trial, primary trial. The MR jet is super wide, you know, so we are putting the biplane here, and you can see that it is even leaking that laterally. So not just in the middle, but it is even leaking laterally. So this is not an easy case for mitral valve surgery. So we randomized him, and unfortunately, I was praying that he randomizes to surgery. He randomized to clip. So we have to do a clip now, and we have to get 2+ MR. So one thing to keep in mind that when you're doing a transeptal puncture, a lot of people use a biplane view to say superior, inferior, and anterior, posterior view. When you do that kind of a puncture, you can see the fossa here. This is the mitral valve. This is the fossa. So if you puncture here, it will be very anterior puncture, but here it will look good. You have to puncture there, posteriorly, right below the mitral valve. This is super important because if you don't puncture right, you cannot align the clip accurately. So here, the typical puncture, people would puncture in the red spot, a little bit higher and posterior. They think they are higher and posterior, but actually they are anterior because this is not posterior, because in the 3D view, you can see that this plane that you cut was anterior. So you have to stick here posteriorly there. So this is how we stuck it. Again, imaging is a very important part of this procedure. So you have to have very good imager. As you saw in the aortic valve, everything you can do, I many times write in the note that if you guys see the mitral valve or tricuspid valve, we'll be able to treat it. So same thing is true, so you have to have good imaging. So now you see the trajectory, beautiful, as if it was designed, that it is coming straight down, straight down, straight down, and now it's like putting a stitch. If you put a crooked stitch on the mitral valve, it will not align properly. And here, if you see that we are doing an RAO view, I align, take out the parallax before I enter, so that if it clip turns, you would know that the clip turned. I know that they gave me 8 minutes, but if you can give me 2 more minutes.
Slides back?
2 or 3, okay, good. So I will maybe make it 3, that will be ideal, but 2 is fine, okay. So then we can optimize the clip to say that we get the posterior leaflet, and if still there is a lateral leak, and again, this is a primary trial, we want to be outstanding, so we will put another clip, and after 2 clips, the patient has great result. If you have the functional mitral regurgitation, more difficult to treat because it's not easy to know where exactly the valve is leaking. So again, the atrial and ventricular views are very important. Many times it leaks on the lateral side. So TE is important. I'll skip the mitral FR and this, but the main idea that I want to just convey that when you see the mitral regurgitation, there's LA and LV dysfunction. If mitral regurgitation is more compared to LA and LV dysfunction, then treating mitral valve makes sense. So keep that in mind. And here, again, how you align the clips, how you put the clips, whether you use wide clip, small clip, all these things are technical challenges. And knowing the mitral hemodynamics is also very, very important that you do before and after. And then you follow the patient to see if the LV remodeling happens. If you are not good with the mitral regurgitation, if it is a difficult mitral valve to treat with a clip, then these days we are using this M3 valve. So this is a ring that you put around, and then through the ring you put a valve replacement. So this is a very simple, relatively simple method of replacing the mitral valve. And this is before and after. You see the valve was leaking, and now the valve is, but however, there is a downside that the LV function can go down with this because the annular function is not preserved. And lastly, I want to say that the carillon device is another device that we use if there's an atrial component of mitral regurgitation. So if there's atrial dilatation, you can put the carillon device, very safe, goes through the neck. And now we are doing the EMPOWER trial. I'm the PI to say that we are doing it for not severe mitral regurgitation, for moderate mitral regurgitation. And so this is a new trial, and there was one little slide there to show that we can do it just from the neck, awake patient, no need for TEE, and this has an outstanding option also. So there are several different techniques that are now being available for mitral valve that you should keep in mind. And this is the particular patient that you saw. But anyway, thank you again for the invitation, and of course, happy to take any questions.